Hello and welcome to the live stream of CGT and online medical consultation on the treatment of this COVID-19 infection. I'm Tom Bo in Wuhan. China Global Television Network arranges the meeting and the platform to help medical professionals from around the world exchange their views and discuss on how to get a grip on COVID-19. If you have any questions for doctors and COVID-19 experts, please leave them in our Facebook comment section below, or use hashtag #MyOpinion on COVID-19 to share your views. CGTN will take your questions to the professionals and discuss them in the live stream. And let me first introduce our participating professionals from Peking Union Medical College Hospital, which was founded in 1921 by the Rockefeller Foundation. It is a national health center guiding the diagnosis and treatment of difficult and serious diseases appointed by the National Health Commission of China. First of all, we have Dr. Fan Junping, pulmonologist from the hospital. Say hi to everyone.
Hi.
And we have Ding Xin, attending doctor, Department of Critical Care Medicine, Peking Union Medical College Hospital.
Hello.
And we have Wu Wei, an associated professor of cardiology in Peking Union Medical College Hospital. And last but not least, we have Xie Jing, an assistant professor at the Department of Infectious Diseases from the hospital. Welcome you all. And also from South Africa, we have Dr. Sorry if I read your name wrong, please do not mind. Oin Senga, team leader, WHO Emergency Program, the Emergency Hub for East and Southern Africa. He is also joining us today. And from Canada, we have with us guests from University of Manitoba, Manitoba Shared Health, Winnipeg Regional Health Authority. And my Patricia Roach from the Canadian side will help me with the North American guests.
Perry, if you just want to say hello. And I see here we have Dr. Eberhard Renner as well. And can you just quickly introduce yourself, Dr. Renner?
Yes, I'm the head of the Department of Medicine and the lead for internal medicine with Shared Health.
Great, thank you. And we have Dr. Ryan Zarychansky. Ryan, if you want to just say hello and introduce yourself quickly.
Yeah, hi there, I'm a hematologist and critical care physician, helping to organize many of the COVID trials in Manitoba. I was actually in Wuhan in the end of September for the Chinese Critical Care Conference and probably met several in the room and still talk with some of the colleagues there. So it's a very interesting connection that from the past.
Thank you. Dr. Rakesh Arora.
Hi, good morning. I'm a cardiac surgeon and intensivist here in Winnipeg and part of a national collaborative on cardiac experts looking at COVID, specifically as it pertains to cardiac illness and the use of ECMO technology in those patients, as well as part of the Society of Thoracic Surgery, a special task force on COVID cardiac thoracic surgery.
Thank you. And I see we have Dr. Chris Tudulu. Can you introduce yourself? Can you hear us, Chris? I don't know if he is connected via audio. And then we have a number of other attendees. It's difficult for me to tell who exactly is on the line. So please take a chance to speak up now if you want to ask any questions connecting your voice. Hi. Go ahead.
Hi, Dr. Boyan Ponovic, Provincial Lead for Critical Care and President of the Canadian Critical Care Society.
Thank you. Anyone else?
Hey,
Okay. Well, yes. Okay. The meeting today is going to touch upon, but not limited to, topics of cardiac, ECMO, and ICU treatment. So we can start the Q&A sessions. We can start it free now. Any questions for our medics from Beijing?
We have a list of several. Perry, do you want to get started, and then I can go in my cardiac?
Yeah, sure. Please.
No, Kesh, go ahead and start with your questions first.
Okay, great. I have a series of them, and if I'm going either too fast or too slow, please let me know and I can slow down and ask the question again. So these are sort of collected on behalf of myself and about 12 centers across Canada. To come up with some questions we wanted to ask you. Some of these we know there are several publications, but we're interested in your personal and direct insights into some of these. So the first one would be, what were the most common cardiac-specific complications of the COVID-19 that you observed within your patients and in the initial experience in China?
Okay. So can you hear me? Okay. Dr. Wu, I'm a cardiology doctor. So I heard your questions. What is the most common cardiac-specific complications? I think the myocardial injury. Yes, myocardial injury. That's we can find for all of us, our opinion, clinical opinion is based on the single ICU patients. So from my observation, about 77 patients in our ICU, more than 50% of patient have the elevated cardiac troponin. That's positive. So the second thing is, I think the arrhythmia. Arrhythmia is including ventricular arrhythmia and supraventricular arrhythmia. Actually, there's more than 10 patients had atrial fibrillation, and several cases with ventricular fibrillation and sudden cardiac death. So the last thing is, I think acute coronary syndrome is not a big problem because two patients with previous myocardial injury, myocardial infarction, and triple vessel disease died suddenly. There's no chance to make the diagnosis of acute coronary syndrome.
So I've looked to my right here because I'm making notes as we go along, so don't get mistake if you're not paying attention. So along those lines, and some of the early experiences I've had with ourselves and our colleagues in the United States have been that this has been largely biventricular dysfunction, not just limited to the left ventricle. Has that been your experience as well, sort of pan-cardiac myocardial involvement?
We do a lot of echocardiography for these patients, bedside echocardiography, and I think most patient has normal left ventricular ejection fraction. Most patient. There are some cases with reduced ejection fraction, but the problem is they had previous coronary artery disease or maybe dilated cardiomyopathy. There are several cases with pulmonary hypertension, but it's one based on previous COPD, and the other two I think may be caused by the pulmonary injury. All the people have ARDS.
What are the sudden deaths from? Sorry.
There are several various causes of sudden cardiac death. One is the electrolyte disorder, like hypokalemia and hyperkalemia. And the other two cases, I think they had the very severe hypoxia. So the patient, when we intubate the patient, and the patient had sudden cardiac death. And the two cases with previous coronary artery disease.
So you alluded to this as part of your response with regards to LV function. Were a number of these patients with significant cardiac issues primarily older adults, so people whom would have higher rates of unrecognized or perhaps undiagnosed cardiac disease, or was this also happening in younger patients in the 20s, 30s, and 40s as well?
Yes, the latter one. The youngest patient in our ICU is like 26 years old, and the other two patients are in their 30s. The youngest one died at the 47 years old. The youngest one died, and they don't have any previous heart disease. Okay. But actually, the older people have much higher mortality and comorbidity with cardiovascular complications.
Great, thank you for that. One of the things we're trying to determine what to do is, as you alluded to as well, that a number of your patients, greater than 50%, had a troponin rise. Were these large troponin rises or small ones or intermediate? And what was your diagnostic approach when you had those patients?
First, I think cardiology doctors should stand on the bedside, go to the front line and see the patient. And most of my the elevation of the troponin is a little bit mild to moderate increase. Several cases with very high, but they have. I just have mentioned that they have the pre-existing coronary artery disease. And what's your next question? Sorry.
So I think that was it. So the next one will be with regards to, and this is probably a bit granular, but I'll ask it with regards to the use of ACE inhibitors and angiotensin blockers. Both the American College of Surgery and the Canadian Cardiovascular Societies have recommended against the discontinuation of these medications.
Okay.
There has been a lot of controversy around that. I was wondering what your experience has been.
I think it's a really big controversy because ACE inhibitor was regarded as increased ACE2 receptor in myocardium or in the other tissue. But in my personal opinion, I think that's it's not being discussed fully. And I think ACE inhibitor may increase the possibility of COVID-19 infection, the virus infection, maybe, and that's theoretically. But if the patient had more than like 3 or 4 weeks later, like recovered or admitted in the ICU, the nucleic acid test is usually not negative, and the patient have developed the antibody. So I don't think ACE inhibitor is a major drug to control hypertension or heart failure should be stopped at this stage. That's my personal opinion.
Okay. For the heart problem, I have something to say that as I'm an ICU doctor, not a cardiologist, but I have to say that we must pay more attention to the right ventricular dysfunction, because in our patients, a few of them have developed left ventricular dysfunction, but the percentage is not so many, because just the Dr. Wu said, only several of them developed left ventricular dysfunction. But as most of these patients are ARDS patients, and we have found that about 50 to 70 patients, 70% of patients developed right ventricular dysfunction, such as pulmonary hypertension. And you have found that enlarged right ventricle, and this may contribute to some circulatory turbulence, circulatory unstable of these patients. So if you evaluate these patients, especially these patients' cardiac function, pay attention to their right ventricle, not only the left ventricle. Okay.
That's really important insight. So, other than treating obviously the underlying pulmonary pathology, what was your approach to treating the RV dysfunction in these patients?
RV or LV?
Dysfunction. RV dysfunction.
The RV dysfunction as just described.
Just as I said, that we thought that most of the RV dysfunction are caused by the ARDS, so we don't have enough drugs or enough medicine to treat that kind of pulmonary hypertension. What we have to do is to improve their oxygenization and reduce their ventilation parameters. Okay, not especially for the heart.
And fluid control.
And fluid control, sure. Great. One of the questions we had for some of our community cardiologists as well as what sort of protocols or planning should be recommended for the CV, like the cardiovascular provider, not necessarily one within the cardiac environment, but those taking care of these patients potentially in non-teaching and more community-based sites.
I think most of the cardiologists should have first be trained, have experience in ICU. And the second thing is they should be skillful with a lot of things which will be done on the bedside, like electrocardiogram and echocardiography. You know, the patient had no chance to be sent to the cath lab because it's a guaranteed ICU and the quarantine ICU and the quarantine patient. It's not applicable to send them to the cath lab.
Right. Okay, so not a lot of intervention work on these patients, which makes a lot of sense. So what I'm hearing is that there's a lot of arrhythmias, a lot of sudden death, that maybe part of the cardiac is secondary to the pulmonary disease with associated RV involvement, that these involve younger as well as older patients. The rate of LV dysfunction is relatively uncommon, but it's more common perhaps in older people who may have underlying cardiac disease, and you were continuing the use of ACE and ARBs in these patients if you weren't necessarily discontinuing them. Great.
I heard something just a little bit different, Rakesh. I heard that the majority of cardiac disease is in older people with significant CV and respiratory comorbidities. Troponin increases are generally mild, or LV dysfunction is generally preserved, and the early deaths were due to hypoxia and electrolyte abnormalities and not lethal cardiac arrhythmia. And that's kind of what I heard there.
We just mentioned that we just said is the experience from our patients, our ICU, and we from now until now we have got 95 patients, and we were not very familiar with other data or other information about the patients from other ICU. So we just share the experience of our patients. Maybe things are different.
Mm-hmm. Could I ask a question? Do you mind, or was there?
Sure, go ahead. Ask an echo question, but go ahead.
Yeah. My colleagues from France, Ryan Zerchansky here, have been emailing me because they've been struck by their clinical observation that while the patients are severely hypoxemic, their lung mechanics are not as severe as one would expect in many cases of ARDS. And so where the plateau pressures are not sky high, and there seems to be more of a dead space issue than more of a difficult to inflate or mechanically ventilate. What has your experience in mechanical ventilation and parameters in people with ARDS? Because they have a hypothesis around this, so I wanted to see if you shared that observation.
Well, I'm a pulmonologist. I'd like to share something on this subject. Well, what you have heard from your friends or colleagues are probably similar to what we have found here. Those patients with
Chris, you need to go on mute, Chris.
Yeah, we can't hear the response.
Well, I totally agree with you that the patients of COVID-19 in many aspects are very different from patients with ARDS caused by other pathogens or other causes. For example, H1N1 influenza. They're totally different. Well, in our COVID patients, which are admitted to the ICU or intubated, we observed that the hypoxemia happened gradually. At the very beginning, they might only have mild symptoms of short of breath. Then later, they need oxygen, and they can go with nasal cannulation for several days, then non-invasive ventilation for several days, then get intubated. And at the very beginning of intubation, the conditions or the parameters of the ventilator is kind of acceptable. As you have mentioned, the plateau pressure is not high, and the compliance is acceptable. But the problem here is they do not recover very quickly. They're gonna exacerbate all the time, maybe gradually, a little by little, but they do not recover. Not just like the patients we are familiar with H1N1 influenza ARDS, which go to the peak stage very quickly and they recover kind of kind of sooner. But these patients, the hypoxemia goes gradually, and the recovery is very hard to see. That's our observation.
I asked the question because it kind of helps us understand what kind of ventilators we're going to need if we get overwhelmed, and it doesn't sound like it sounds like the compliance is generally not the issue, and many ventilators will fit the bill as long as it can deliver oxygen. And I also asked the question because I've been getting a lot of questions about our heparin trial that we're running around the world, but out of Canada here, about heparin anticoagulation and septic shock, because the French are giving heparin, apparently, that's what they're writing me in an email, routinely now up front, because they feel it reduces 1, inflammation, 2, early deaths, they think, and 3, is that there's some issue, some in vitro data that the viral adhesion to the endothelium is blocked by heparin, and they're really enamored with this, they're really excited by it. I mean, none of it is, I mean, it's very interesting, and especially for me as leading this HALO trial. But have you had any experience or observation of early deaths due to thrombosis, suggestion that heparin is at all beneficial? Because it's all very new to me, and I'm trying to process these emails coming in.
Yeah, we had the similar impression on anticoagulation and coagulopathy. We have observed that a large quantity of patients have experienced a clinical scenario of DIC, disseminated intravascular coagulopathy. A very obvious physical sign was the extremity gangrenes or black spots. When the people, and also from our coagulation test, you will find very high PT and APTT as well as D-dimer. We believe that's a very important indicator for a poor prognosis in such patients. We have emphasized a lot on early coagulation, especially when you suspect the patient is having a DIC. Well, unfortunately, those patients may have improvement on coagulation tests. You may have a decreased D-dimer after coagulation. However, they suffer a lot from heparin-related bleeding, deep ones and on the surface area, and also if the patient have gangrene, I mean the toes or the fingers get black, they are hardly surviving. That's our observation.
Yeah. Okay.
And I try to mention that more than 30% of patients has the elevated D-dimer up to the upper level that the machine can test.
Yeah.
And more than 50% of the patients receive the heparin or the molecular weight heparin to prevent the thrombosis.
Yeah. Well, have you had early deaths due to pulmonary embolism or large vessel thrombosis?
No. And also, it's very hard to do a contrasted CT scan among those patients. We have done non-contrasted CT scans, but in more stable patients. And one more thing for the ventilator. Well, a significant experience of us is if you delay the ventilator. I mean, from non-invasive ones to mechanical ventilator. If you delay them for a very long time, it's bad for the prognosis. So if you evaluate a patient that he or she is eligible for intubation and mechanical ventilation, just do it. You don't delay them by an IV, because the hypoxemia might seem okay before the intubation, but actually maybe they need one.
Okay, can we have our guest from South Africa? We can give him a chance to ask questions. Dr. Sanger, do you have
just
any
off them up. Sorry.
Dr. Sanger, do you have any question for us? You're on mute.
Yeah, I can hear you. Okay.
Good.
Okay.
Do you have any questions for us?
Anything at this point? No, I think this is on the clinical form of patients in Africa so far. I mean, the return is a little bit too early. We are starting only to collect information on patients, so we don't have that kind of analysis so far. Over.
Okay. Any other kind of medical help or support that?
Okay, I have one follow-up here. There's an enormous amount of enthusiasm in North America and a lot of emotion around the potential for hydroxychloroquine to prevent disease or treat disease. We have started many international trials, and I see you're chuckling a little bit under your masks even, and I hope that's because of Donald Trump and not because of us. We are participating in many clinical trials around this and are leading several also. And I presume, I can only presume that in the New England Journal of Medicine the next day or the next day or the next day, studies from China are going to be published. But do you have any indication about whether this is beneficial and where it's beneficial, hydroxychloroquine or any other drugs at this time, that you could share your perspectives?
Well, thank you for the question. I'll take that one. As ACU doctors, we believe antivirals such as or other medications such as hydroxychloroquine is not useful among our patients, just because the PCR test of them in various samples are negative. So we believe we are dealing with the results of the viral infection, not the virus itself. However, after collecting the perspective and the experience from other medical staff or medical workers who also fought the COVID-19 in Wuhan, they are using medication such as hydroxychloroquine per guideline, the 6th edition maybe. Well, what they are observed is in mild form of diseases, the patient all get well. Only a small amount of them were transferred into further hospitalization or intensive care units. But in terms of efficacy, it's hard to evaluate just because there is no control trial yet. Yes, I have searched the paper published by the French scholar involving or concerning the use of hydroxychloroquine. It's a very small one, very small trial, and it's not controlled. I agree. More patients can participate in the clinical trial using hydroxychloroquine. At this time point, my personal opinion is just because hydroxychloroquine is a very old generic medicine, and the experience and observation of this drug for medical society all over the world is very, very sufficient. So if you feeling that you want to use it, just use it, just because the side effect is acceptable generally. But you should. I think we should pay attention to the side effects of it, just because there are some reports.
That's our observations too. Is that we're also interested by the data. We're unimpressed by what's done thus far, and that we're trying to contribute to the evidence base as much as we can. We shouldn't feel bad if we don't give it. Although you didn't say that, but you clearly don't acknowledge that there's obvious benefit to date yet.
Hi, it's Dr. Perry Gray. Got a couple of questions picking up on, it's not wise to take these patients to the cath lab for intervention because of infectious reasons. How important is it that these patients not leave the ICU and infect the rest of the hospital? Or is it just the cath lab? You also mentioned really couldn't go to CT scan to get an infused CT. Is that the way you managed the patients? They essentially just stayed in the ICU and you brought all the technology to them?
I can take the question. Thank you. Because I work now in the ICU, but my colleague in Peking Union Medical College Hospital are dealing with the acute myocardial infarction patients who were suspect or not suspect with COVID-19. And usually in ST elevation myocardial infarction patients, if the patient was sent to the ER, they take the ECG and identify the myocardial infarction. We usually use thrombolysis therapy, thrombolysis. At the same time, we will do the throat swab, to test the nucleic acid, and send the patient to the CT scan. in case the failed, thrombolysis may fail. But in 2 hours, we will get the nucleic acid test and the CT scan and decide whether we should send to the cath lab for the rescue PCI or can, the thrombolysis succeed and we can do the elective angiography.
Okay, well, thank you. That is a very great answer, and it just triggered my next question. There is a lot of controversy here about the test versus the uninfused CT scan, and do you need both? Or are the swabs negative, but the CT scan is positive, and did you rely on the CT scan? What was your experience with the uninfused CT scan versus the PCR test?
Okay, I'm going to answer your question. I think, in our opinion, the most important thing is take a comprehensive and dynamic process to diagnose your patient, rather than rely on a certain type of test. I think both the PCR test for the nucleic acid of the virus and the CT scan, both of them are important for the diagnosis. Actually, in the Hubei province, the epicenter in China, when we lack of the PCR kits, we temporarily use the clinical diagnosis criteria for a while. We do the CT scan for the patient, and without considering the PCR test result.
Yeah, I agree with Dr. Xie, and I have something to add. Well, the story here in China is epidemiological history is important, CT scan is important, PCR test is important, but neither of them are perfect. They all suffer from false positivity or false negativity, mainly false negativity. So we suggest using them holistically. When you are not sure, but you suspect the patient is suffering from COVID-19, isolate them, make them quarantine, just to keep safety and further transmission. But we do believe all of them are important.
Yeah, we actually classify the patients with the confirmed cases and suspected cases. Both of them are quarantined. We provide multiple round of tests for the suspected cases.
So that's excellent. So what you're saying is we cannot rely on a negative PCR alone,
right,
necessarily, especially if the clinical suspicion is high. And then you touched on my next question. It's like you're reading my mind. We are probably not being aggressive enough here in Canada with case isolation. We're sending the positive patient back home with the family and telling the family to self-quarantine. Would you recommend we get more aggressive, and if a patient's got the symptoms and we suspect the diagnosis, they should be isolated or cohorted with other patients who have been proven to have the diagnosis?
Well, yeah, we recommend we recommend strict quarantine or strict isolation for suspected patients. Just because the family clusters here in Wuhan is very prevalent. When we lose a patient in the ICU, we call their family. One or some of their family members are also in hospital. We see it a lot. I believe the transmission capacity of this COVID-19 virus is very, very high. The transmission capacity is very high. So family quarantine is very hard to complete for an ordinary citizen. It's very hard.
But if we are fortunate in the sense that we're still early here in Manitoba and have very small numbers and can aggressively isolate. You would recommend we very aggressively isolate.
Yeah.
Okay. The electrolyte problems in your intensive care unit. How many patients developed renal failure, and were you able to give them dialysis or continuous renal replacement therapy?
Okay. We, like in 77 patients, we had 25 patients had acute kidney injury, and most patients, if they developed renal failure, we will provide hemodialysis. No problem. We can do
that. And did any particular risk factor for developing acute kidney injury in the group? Those on ACE inhibitors at home, or ARBs at home, or it just was random?
I didn't do the analysis because I'm a cardiology doctor. But in my data, I think the pre-existing disease like hypertension, diabetes, and chronic kidney disease is the risk factors. But the ACE inhibitor and the ARB, we don't think so.
Okay.
Oh, that's one case. One case is caused. I think that's caused by the antiviral agent, remdesivir.
3 cases.
3 cases?
3 cases.
Okay, 3 cases remdesivir.
And someone already asked this question, but I may ask it a different way. We have a kind of standardized approach to ARDS, as I'm sure you do. Did any of the particular ARDS maneuvers, such as proning the patient, did any of those, in your experience, were they more or likely to be successful or not within the ARDS management?
Okay, for the ARDS management, first we think we have to stick to the long protective ventilation strategy. That's the basic principles, as those. That means low tidal volume and low levels of airway platform pressure. And for the more severe patients, we think per position ventilation, more than 12 to 16 hours per day is effective at the beginning of the ARDS. And we can see the oxidation can improve obviously. And at the beginning of the ARDS, we think the group maneuver may get some will have some benefit for the patients. But I have to say that this ARDS is different from that caused by H1N1 and other flu, that the patients getting worse and worse. And from when the patients intubated for a long time, such as a week to 10 days or 2 weeks, this kind of methods, such as proning, such as IM, they are not as effective as the beginning. And we think that's the difference from the ARDS caused by COVID-19 and compared to other kind of flus or viruses. And that's why the survival rate is relatively low in these patients.
Yeah, I agree with Dr. Ding. Early intubation, appropriate prompt positioning, and prevention of secondary infection is among the few weapons we can use treating these patients. And the mortality still is very high.
I think Dr. Aurora
Can I
has
ask a question
more
along those lines?
questions.
Just very quickly. For those patients who were mechanically ventilated, what was the rate of liberation? How many people were you successfully get off the ventilator once they were placed on?
Actually, we just have the numbers, and I can share with you. Till now we have about 95 patients in all, and 65 of them have been intubated with mechanical ventilation. And let me find the number. Just wait a moment, okay? Till now, just about 8 of them was successful mechanical ventilation liberation. That's about 12.3%. That's not a very good number, but to our experience, and we communicated with all our colleagues who also fight in Wuhan, and that percentage is not the worst, but maybe some ICU do better than us, but in most ICU we have the same experience. Maybe just 10 to 20% of them can successfully liberate from the mechanical ventilation.
What was your longest length of stay of the ones who did survive? What was your longest length of stay on the ventilator?
Yeah, I have case 30 days. 73-year-old woman. She was ventilated for 30 days, and she survived.
Dr. Renner, any questions from you? You're on mute.
You're on mute. You're on mute, Abby.
Thank you. Well, I have a question that's not directly related to ICU. What is the relationship between the ICU beds you use and the internal medicine beds you have?
Well, we do it together. They are very free transferring between us. The general medical wards are for mild disease. But once they get exacerbated or need ICU support, they're going to contact us.
So, to be more precise, how many ICU beds do you have, and how many internal medicine beds?
We don't have the precise statistics here, but from what we know, in the special hospital set up for COVID-19 in this epidemic, we have in the same campus 4 ICU wards. We are one of them. We have 32 beds, which are all open for them, and there are about more than 10 medical wards at the same time. That's what we know.
It's interesting. It's interesting.
The approximate ratio of ICU patients to ward patients is 1 ICU patient, 2 ward patients, 1 ICU patient, 3 ward patients. What was the ratio of patients with COVID on the ward versus in the ICU, if you have it approximately?
I think we have 2 ICU ward and about 10 general internal medicine wards.
Okay, I think I can answer this question because in our special hospital designed for the special patients with COVID-19, we have 2 ICU wards, and each of the ICU have 32 beds. As in all, we have 64 beds for the ICU patients, and our whole hospital we about have 1,000 beds here, and we don't know whether the hospital was full of patients when, but we just got about 1,000 beds here for the other patients, and we have 64 beds for the ICU patients here. In our hospital.
Wuhan.
In our hospital.
Beijing.
Wuhan.
That's a little bit hard to, just understand in total, because we're not sure why everyone was admitted even to the hospital. Were people admitted to the hospital just for isolation? Because
No.
For treatment.
Or were they admitted for actual medical treatment? Because I know you have a pretty not aggressive, but a pretty deliberate and strategy to isolate those who are positive. Are those within the hospital or within another facility?
Oh, no. All these patients here are for treatment. We have different kinds of hospitals, and those were suspected patients or those patients who are not so severe, we call that mild patient. They are in other hospitals. But in our hospital, most of them, all of the patients were confirmed, and several of them have severe. And in our ICU, they are critical patients.
Well, a very important creation in this pandemic here in Wuhan is module hospitals. The government changed gymnasiums and the stadiums into simplified version of hospitals quickly. They can provide thousands of beds. I believe most of the mild patients are hospitalized there with certain medical civilians and also with medical staff. They do not need oxygenation. They do not need, but once they develop hypoxemia, they will be transferred to hospital into internal medicine wards, especially such as those beds which are provided in our campus. But when the patient meets the criteria of ICU admission, which means the hypoxemia develop into a more severe form, they will be coordinated into ICU stay. That's what we do here.
Okay, Dr. Aurora, I think you want to ask some more questions.
Yes, just I know we're running out of time here, but I wanted to ask a few questions. Your experience with using ECMO for some of the patients with really refractory ARDS that were not being adequately supported with mechanical ventilation. What was your experience with that? I know the overall rate from the initial report from the New England paper was about 0.5% of all patients. Some other centers are using it in Europe a bit more liberally. I was curious on your experience.
Okay, I think we have to divide our fight here, and we have been here for about 2 months, and at the first month and the second month, they are most different. And at the first month, actually we don't have so much machines. We don't have so many ECMO machines, and many of the patients are suffer from very severe ARDS, and from all the guidelines, all these patients could and should be use the ECMO to just get the time for them to prepare. But you think that as we don't have that enough machines, and just a few of the patients can get the therapy. Till now we just have 5 patients who were treated with ECMO, and unfortunately 4 of them have passed away, and the only one here, and we still have the machine running here, and we think we are trying our best to get a better result, but we don't think it is very easy thing for us. And we have heard that in several of the ICUs in Wuhan, maybe some teams get a better result. And I heard that in one ICU, they have 5 patients with ECMO, and 4 of them have liberated. So had just a winning, had a winning from non-ECMO. And that's the best I've seen. And all the other ICUs, and their conditions is just like us. Most of the patients with ECMO, they just passed away. And I think because we are short of machines at the first time, and when the patients have to be treated with ECMO, actually it's not a very, very proper timing. Maybe this patient can be started with ECMO therapy at the very beginning when they meet the criteria, such as the oxygen index is less than 80, but just as we don't have that machine, we have to let the ventilator to treat the patient for a long time, and we know that the ventilator-induced lung injury is very, very severe at that circumstance. So we don't think that ECMO is very good for these patients. But as gradually several of our teams got enough ECMO, so maybe these patients can be timely treated with ECMO, and I think the survival rate can improve at that circumstance. So this is our experience about the ECMO. But actually, ECMO is a very good power. It's a very powerful machine for life support. But we think that it can only gain more time for the patient to recover, to give our doctors more time to treat that patient. It cannot improve the mortality of these diseases. And actually, as an ICU doctor, I sincerely hope that we don't have to talk about the ICU program, the ECMO programs, because if we are talking about the ECMO programs, most of our patients have been very, very severe, and most of them will have to lose most of them. And I think timely, adequate oxygen support, timely intubation, and use preposition, use just a non-protective ventilation to make the patient didn't get second hit caused by the ventilator-induced lungs injury. That is makes more sense for these patients. And if the patient has to be treated with ECMO, if you have the machine, just start the ECMO treatment as soon as possible. Maybe that can give this patient a more chance. And if the patient just get more MODS and get several organs have been destroyed by the disease, I don't think ECMO is a very good choice for these patients.
Well, despite what Dr. Ding have said, which I agree a lot, three things have limited the use and benefit of ECMO among ICU patients of COVID-19. The first, the irreversibility of this disease is very difficult. We don't easily observe irreversibility among these patients. The second, the patient always suffer a lot from secondary things such as bacterial infection. And also the third, there are always a shortage of such things. And also the patient's age is relatively high. A large quantity of them are above 60 years old, which all limited the use of ECMO.
Okay, Dr. Sanger, do you have any comments to make?
Yeah, thank you very much. Thank you, colleague, for this discussion. I'll make a comment that is not on clinical medicine, but following the question that came about isolation. First, in Africa, isolation is mandatory for all who test positive. It's a mandatory. Whoever tests positive has to be isolated in government site. And in addition to isolation of those who test positive, we also self-isolation for those contact. Whoever is counted as contact is encouraged by government to encourage or put in self-isolation. And quarantine is also mandatory now in many African countries for those coming from affected countries. Now, one question may be from my colleagues in China. Now we are at around 1,000 cases, more than 1,000 cases in Africa. At the beginning of the outbreak, we had 80% of all cases were imported cases. But until now, we haven't received any imported cases from China. All imported cases, so now the question is, were they kind of exit screening put in place for those coming out or going out? Because when you compare the volume of flight and the volume of exchange between China and other countries, is basically very high with Africa. So the question I was asking is, did you put in place some exit screening for those traveling out, and how effective those measures were?
Well, thank you for the question. I can try to answer the question from my perspective. First of all, we know Hubei has a lot of patients of COVID-19 in the last 2 months, but other provinces, other than Hubei, there are not so many cases. Most of them are imported from or are people who worked in Wuhan or have certain contact with Wuhan. So because there are a lot, China has a large population, so we can say that most of the traveling persons from China, not from the epidemic area. Secondly, at the beginning of the epidemic in Wuhan, it's all coincided with the Chinese festival. We basically go home or stay at home. And after the outbreak of COVID-19, the government encouraged all every citizen to stay at home, no matter you are in Hubei, in Wuhan, or in other city. We have canceled our travel, especially international ones. That kind of explains why the imported cases in Africa are rarely from China.
And I totally agree with Dr. Fan, and also we pay a lot of much attention to the contact tracing. For each confirmed cases, we finish their contact tracing in 24 hours, and for the people without epidemiological history, without symptoms, without other clues for the infection, I don't think we need the exit screening for everybody.
Could I ask a quick question? Which is, if you had positive patients on the wards, were you okay having them as part of the general hospital with other COVID negative patients and general, gynecologic or surgical patients, or did you isolate all of the COVID patients to a separate building? That was number one. And number two, when did you let them leave? Like, did you have certain criteria regarding their testing or negativity before you let them go in the community? So that's two questions there. How did you isolate them in your hospital and let them mix with other patients? And then what was your exit criteria from the hospital?
Okay, we have a designated hospital for the COVID-19 patients. For the general hospital, if you have confirmed cases, all these cases will be transferred to the designated hospital. It's a special hospital for the COVID-19 patients. And the second question is the criteria for the discharge of the cases, right?
Yes.
Okay. The criteria include 4 items. First is normal body temperature for at least 3 days. Second one is significantly recovered respiratory symptoms. The third is the obvious absorption and recovery of the lung imaging. The fourth one is the negative result of the PCR test for consecutive 2 times with at least 24 hours of sampling interval. And we also recommend for the discharged patients for additional 2 weeks of the health monitoring and self-isolation. And we also recommend them to go back to the hospital at the 2nd and 4th week to get a follow-up visit.
Yeah, they're going to be sent to rehab center, which can be, they can be taken care of for another 2 weeks after discharge.
Oh, yeah.
Thank you very much.
Okay, I think one last question from Dr. Arora. You want to add something about the ECMO?
Yeah, sorry, just with regards to the ECMO, how long were you keeping them on if you were to put someone in ECMO before you determined that it was not working and not a value and discontinued? Were you leaving them on for 40 hours, a week?
Actually, we let the machine run as long as we can. We didn't discontinue the ECMO actively, but sometimes you know that if you have some septic shock, you have the blockage, you have just the strongest of the membranes, and the ECMO can be destroyed here, and you can't have the machine just run properly, and we have to discontinue the ECMO therapy. But if we can make the ECMO run properly, we didn't actively discontinue that therapy. And that's just and that's also one reason we shut off that machines, because most of our ECMO patients they are running on ECMO for a long time.
And we should communicate with the family members and discuss the whole situation with family member, and ask their opinion and respect their opinion.
Okay, thank you very much.
And how long sorry,
Yeah, because of the
Rakesh,
time.
can I can follow up, but in regards to that, were there any triage making decisions about patients you would admit or not admit or discontinue on at any time during this for you, outside of ECMO?
Sorry, could you repeat the question again?
Looking to see if you had any triage criteria about limiting admission to ICU or ventilation.
Well, there's no limitation for mechanical ventilation or ICU admission because the government has augmented the capability and beds in both settings. In terms of ECMO support, there's no such charge either. Not because there's enough. Because we did not experience a crisis of charge among people who is about to achieve ECMO. Just because most of the patients, just like I mentioned, did not see a high possibility of reversibility of the disease course, and also most of them are above the age of 70. So we'll try patients who are most eligible and most likely to recover, but we do not count on it too much, given the features or characteristics of these patients and the prognosis.
Okay, thank you very much. Before we go, I want to ask Dr. Perry Gray, what do you think of this online consultation, and what's your take on it? And we will answer your questions.
I want to thank all of you for taking the time to share your experience with us. We are very grateful for your input. We also congratulate you and your country on the amazing job it did to contain the epidemic within your country, and we really hope to learn from you. So thank you very much on behalf of all of us.
Okay, thank you. Thank you for all your participation. And we know that right now China has kept the virus under control largely, but still meetings like this are quite necessary and important for us to exchange views and cooperation to let us fight the pandemic more effectively and let us unite as one. Thank you very much for participation. Thank you very much for joining us. And have a nice day. Bye for now. Stay tuned.
Thank you.
Thank you very much, guys.
Thank you.
Thank you very much.